So thanks for coming. Today we're going to kind of take off from where we were last month when we talked about common respiratory emergencies, and now we're going to talk about airway problems. Um, Hopefully you guys remember your anatomy because I didn't put the anatomy and stuff since we just went over it last month. All right, so obviously we're going to see a whole bunch of products when we go through this. Just because I'm talking about a product doesn't mean that it's necessarily an endorsement. So the objectives are to discuss advanced endotracheal intubation, some of the problems that we have with intubation and EMS, some of the alternative and rescue airways that are out there, and then I'm going to be going around to the various Sharonville stations and doing a practical session, assuming that we don't get interrupted with runs like we did yesterday. Never happens. So why do we need to control the airway? I think it gets pounded into us at a fairly early part in our career where, GCS of less than 8, you must intubate. Altered mental status is one of the more common reasons that we will need to control somebody's airway. Either it's because they're not maintaining their airway themselves, or because we're worried that, they're going to vomit, aspirate, whatever the case may be. It may be that they're having massive bleeding or secretions, and we can't let them, potentially aspirate the blood and secretions. They may be apneic. Obviously, that's a real good reason to intubate. Or they may have ineffective ventilation. We'll see this sometimes in COPDers where their end tidal carbon dioxide levels will get so high that they get this carbon dioxide, kind of narcosis. And so they'll get really confused and combative at times, et cetera. And the only way to fix it is to begin helping them breathe and blow off that excess CO2. Sometimes it's because we can't effectively bag the patient. So we've put in nasopharyngeal airways, we've put in an oropharyngeal airway, still not effective at bagging the patient. And so we need to do something more advanced. Or we've got an unstable airway. We have somebody who has significant burns, angioedema, something like that, where we have a narrow window of time that we can gain control of the airway and actually be able to successfully pass a tube. So the first step whenever you approach an airway is you need to predict your airway. So the acronym that is out there is LEMON, all right? So the first step of that is we look. We look for things that are going to make an airway difficult. Is it, positioning? Is it the environment? Is it, lack of equipment right there at the bedside? Those kinds of things. So look around, make sure that you've got what you need to be able to successfully do this. We then want to evaluate using the 3-3-2 rule. The 3-3-2 rule is the graphic that's on the top there. And it's really actually pretty simple and it makes some sense. So the first one is 3 fingers. Can you open the mouth? 3 fingers. It makes sense because if you can only open your mouth 1 finger or 2 fingers, there's not a whole heck of a lot of room in there that you're going to be able to get a laryngoscope along with, suction and a tube and stuff like that. So having a freely mobile jaw really helps. The next is the hyomental distance, which is from the tip of your mandible, okay, all the way back to your hyoid bone, which kind of sits about halfway between your chin and your Adam's apple. What that is telling us is how far anterior or posterior that airway is. If you remember, when you're looking with your laryngoscope, okay, up is anterior, all right, and down is posterior. So if we have somebody that has a very anterior airway, say they only have 2 finger breadths or 1 finger breadth distance there, that means that airway is very anterior. It means we have to work harder to be able to get an adequate view. So we actually want more than 3 fingers there as well. So that way we can see, that airway much more easily. It'll fall into view a lot easier. And then 2, which is the distance between the Adam's apple and your cricoid. Okay, that also tells us kind of how long that larynx area is and how good of a cricoid membrane we potentially have in case we need to do a surgical airway. If you do those three things, that tells you a lot about, the mechanics of this. We then need to look at the malampati. And again, you don't have to remember the word malampati, et cetera, but you want to get the idea. The idea is the bottom graphic there. The more soft tissue that you have in the back of your throat, the more stuff there is to get in your way. Kind of makes sense. CPAP, or I'm sorry, sleep apnea patients frequently are in the malampati 3 or 4 because they have a lot of soft tissue back there that potentially is going to get in our way when we go to intubate. So if we look in there, and this is just opening the mouth, this is not going ah or anything like that. We're not able to get patients to say ah when we're trying to intubate them. So we want to look at how that tissue is falling in its natural state. So if we look back there, we see a ton of soft tissue. Okay, this is going to be a more difficult airway than otherwise. O is for obstruction. So we want to look for anything that might obstruct us. Is that external things such as a C-collar? Is it the dentures that the patient's wearing? Is it potentially vomitus or other secretions or foreign bodies? So any of that you want to try and mitigate as much as you can. And then the last one is N, neck. Does it move freely? It makes sense that if that neck is either, rigidly in place because of, some condition that they have, they may have had a cervical fusion or something like that, or because they've got penetrating injury to the neck and we're trying to minimize movement. Not being able to manipulate the location of that head in relation to the rest of the body makes it more difficult. There is definitely a skill to being able to correctly position things. And here's our first. Well, at least we got the first run out of the way. So again, it makes a lot of sense that not being able to manipulate that head means that we're going to have potentially difficulty in positioning it so that we can get the best intubation view. So we've now predicted our airway. Let's talk about some of the more advanced techniques. So one thing that frequently gets brought up is rapid sequence intubation. A lot of people have heard about this, et cetera. The use of it, even in the hospital, is somewhat questionable because of the potential, downstream effects of this. So essentially what happens is you are using a high dose sedative and a paralytic. The paralytic is really what causes the potential problem because frequently when you're RSIing someone, they are still semi-conscious or they're still clenching or something like that. They may still be breathing effectively. The problem goes where we now have paralyzed this person. So the more common one that is still used is succinylcholine. That lasts in your system and paralyzes you for about 10 minutes. So what happens is we may have taken somebody who previously was breathing, albeit maybe inadequately, they were breathing, and we've now killed that ability for them to breathe for the next 10 minutes. If we encounter a difficult airway and we're now in a cannot oxygenate, cannot ventilate scenario, we're hosed. We're going to have to cut on this person's neck and, hopefully get a crike, all because of potential use of a paralytic. There's more and more data that says that RSI really needs to be used in the hands of somebody who's extremely experienced and does this on a regular basis. Frequently that's going to be pulmonology or emergency medicine, but you shouldn't be having necessarily everybody under the sun being able to do this because of that potential downstream effect. This is typically what's used in the hospital and in flight EMS intubations because trying to control an airway at 2,000 feet while you're bumping around in turbulence is not fun. So they tend to intubate, fairly aggressively on the ground. It also allows us to intubate combative patients. So if we have somebody who's got a head injury and is clenching, et cetera, and we're not able to, open their airway adequately, et cetera, this allows us to take that out of the mix. In addition to the problems with the respiratory ability with this, another thing that I commonly experience when patients are brought in after having been RSI'd is the idea that the initial sedative dose is enough. Okay, it's not. The initial sedative dose is there so that way we can get this person intubated, and then we need to start, the actual sedation long term so that we can keep this person down. But what happens is frequently that sedative will wear off before the paralytic has. So we now have somebody that is potentially semi-conscious or conscious and is now completely paralyzed, but is still able to feel every single thing that you're doing. I've read, case reports where patients have had this happen to them, and it is frankly frightening, their description of what that feels like. Again, if this is something that enters your scope of practice at some point, you need to be aggressive about beginning sedation as soon as you've got that tube in, because the last thing we want to do is have this person be potentially semi-aware of what's going on to them and they can't do a darn thing about it. The other problem with it is, we really do have a fixed number of intubations. If we look, generally most departments have a fixed number of airways that need intervening on in a given year. Okay, it goes up a little bit every year, but it tends to follow the same trend that our overall run volume tends to occur. So we have a total number of intubations that are available. And if we begin dividing that out, the slice of the pie becomes smaller and smaller and smaller. So if we go to 4 paramedics, now we've got each a theoretically 25% chance of getting a tube. But if we go to 8, well, we've just dropped that, significantly, 12.5%. So it becomes problematic because you've now diluted out the number of intubations amongst a bigger number of paramedics who may be able to do this. The fact of the matter is, though, I think we all know this, there are certain people on every station that are kind of the airway gurus, right? When I had first started as Springfield's medical director, I ran an airway report out of their reporting system, and something like 85% of their intubations were done by 3 people. So those 3 people were obviously very, very, very good at this, and their coworkers recognized that. And so whenever an airway needed to be done, it was, hey, I need you to do this airway. So we even remove further from that, to the point where, if you're assigned to an engine company and that's the only thing you do, you don't rotate onto the ambulance ever, it may be that you go years between your attempts at intubation. And so giving somebody RSI privileges when they're intubating once every 3 to 5 years, not a great idea, because at that point their skills have potentially degraded. So, it's a difficult skill to develop. It's a difficult skill to keep up. A lot of places will, try and get patients, or I'm sorry, try and get their providers into the operating rooms so that way they at least have some airway time. Even if they're not necessarily doing the act of the intubation, having that anesthesiologist go through what a live anatomy looks like, the stuff that they do, the pitfalls, et cetera, it all is beneficial. But again, this is very high risk if you don't do it well. All right, so another advanced technique that we can use is the bougie. Hopefully all of you have had some experience with the bougie. I love the bougie. The bougie is one of my favorite airway devices, period. It's really, really beneficial in difficult airways and in stenotic airways. If I see somebody that looks like they've had a prior tracheostomy scar, it's almost certain that they're going to have some level of stenosis below the vocal cords. And we can't see that with a regular laryngoscope. So what I frequently will do is I will pass a bougie past that tight area, and now I've got a pathway for that airway. I can then have my partner slide down progressively smaller endotracheal tubes until I can finally get it past that stenotic area. So it can really be beneficial and allows you to, maintain kind of control over where that airway is in location to your laryngoscope. It also allows you to intubate without great visualization. If you see on the end of that, there is this kind of tip that is angled upwards. And the reason that is there is so that way you can kind of bounce it off of things. So if you can only see, the bottom part of that larynx, and you can only see those posterior retinoids, you may be able to just simply angle your bougie towards that, and that tip should hopefully help it bounce up into the airway. The other thing that it can do is provide some tactile feedback. As that tip goes in, it's going to click against the tracheal cartilage rings, and so you can feel that. I will say that it took me probably 5 or 6 years of intubating before I finally was able to kind of expand my view and not have such tunnel vision that I was able to actually appreciate feeling that clicking of the bougie going into the airway. So don't necessarily rely on that 100%. I personally like to keep my bougie, naked and not have an endotracheal tube on it like this one is. And the reason for that is you can then roll that bougie kind of between your fingers, almost like you would a pencil. And that takes that tip, and that means that tip is now going from side to side. And so I can then angle the bougie a little bit more effectively. It's harder to do that when you've got an endotracheal tube on the outside because you're kind of relying on plastic on plastic. You've got to squeeze it a little bit harder, that kind of thing. So I frequently will put it in without an endotracheal tube on it, and then have my partner slide the endotracheal tube down it once I'm in position. There is some research that shows that we probably ought to be using a bougie for every single intubation. And the reason for that is that way it gives us more experience with it. We may not need it on every airway, but if we use it on every airway, we're now really good at using it. So that way, when we do encounter a situation where, it's going to be extremely beneficial, we're not uncomfortable with it. We're very adept at using it. We know how to manipulate it. It's not remembering something from training, a year ago. So, highly encourage you. Maybe this should replace your stylet if you use your stylet, because this is better than a stylet. So, does intubation help? Well, we've got a whole bunch of studies on pre-hospital intubation, and these studies have been kind of all over the place. But the end result is, in some cases, the endotracheal intubation doesn't prevent death. In a couple studies, it actually increased their odds of death. There also was either no change or poorer neurologic outcomes when the patient was intubated. And there's a couple different reasons for this. They tried in these studies that have been done to make sure that everybody was as sick as the other group, so they could level things out. It wasn't that the one category had sicker patients, okay? But there's also the act of intubation. If we're not careful, the act of intubation can be harmful. One of the things that I do to mitigate this is if I have enough people on scene, have one person whose sole job is during the act of intubation is just to watch the monitor. That way you can see the moment that person's pulse ox begins to go down, or the moment that person begins to brady down too much. Because at that point, that person needs to alert whoever is doing the intubation, stop, we need to come out, we need to bag, and give this another attempt here in a minute. Because otherwise, you will get fixated. You will get tunnel vision on, I've got to get the tube in the right spot. And it'll be 2-3 minutes of you sitting there with the laryngoscope in, trying to get that airway established. and the person's now hypoxic and bradyed down. So that's one bad thing. The other bad thing that happens, especially with these neuro patients, is we know that hyperventilation is bad. Unfortunately, one of the side effects of us intubating is that most of us are going to end up having to use a bag and don't have access to a ventilator. So because of that, it's easy for us to bag them too aggressively, either with too much volume, too high of a rate, or frequently both. So it's really important that you look at your end tidal capnography so that you know that this person's end tidal is where it is supposed to be. So try and keep it in the normal range. Obviously, if the patient is breathing over that, that's on them. You can still assist their ventilations, but make sure that you're keeping an eye on that end tidal capnography. That way, you can hopefully prevent the hyperventilation and the potential ischemia that comes with it. All right, let's talk quickly about some of the alternative airway devices. Um, I used to have in this lecture, the esophageal obturator airway, the combi tube, et cetera, some of the older things. Those have all been supplanted by newer generation devices. And if you think about it, it kind of makes sense. So one of my gripes with the combi tube was always one, its size. It's just a huge device. And two, it's not firefighter proof. Okay. It has two ports that you have to ventilate through. It has two balloon ports that you have to inflate. And you have to remember in which order to do what thing. And I'm sorry, 2 o'clock in the morning in a house that maybe has one light bulb. Yeah, I'm not going to remember which port to ventilate first or which balloon to inflate first. So that was kind of always my gripe with the combi tube was, okay, it theoretically should work, but it's too darn complicated. So the next thing to come out was the King Airway. And the King Airway, really, I think, changed a lot with pre-hospital care when it comes to airways. It's still blindly inserted just like the combi tube, but instead of having two ports to ventilate through, it now has one port to ventilate through, and it only has one balloon port that inflates kind of both balloons. So it's very simple to use. It's firefighter proof. It does have more consistent esophageal placement, 96.4% of the time, than the combi tube ever did. So that's a good thing. However, anecdotally, I can tell you that one of the problems I have with the King Airway is people will one, overinflate the balloon, okay, and that will cause tearing or trauma to the mucous membranes back there. And or they don't hold it in place when they're inflating those balloons. And so what happens is that larger balloon will actually shove the King Airway out of the area it's supposed to be in. And I've encountered numerous cases where, basically that balloon is at their teeth. So it's not anywhere where it is supposed to be, and the fact that they still have an airway at all is kind of miraculous. So those were my two biggest gripes with it. Still a great airway. If that's the only thing you've got access to, it's still a great airway. Still continue to use it. You just have to know how to use it. Okay. The iGel was kind of the next thing to hit the market with wide acceptance. The iGel is essentially a laryngeal mask airway that anesthesiology has been using for decades, except instead of having an air balloon that makes the seal around the larynx, it now has this heat reactive gel that is supposed to conform to the area nicely. It's a great airway. It is even more firefighter proof because there's nothing to inflate now, so we don't even have that to worry about. And it is very effective. It works very well. It just like the King Airway does not necessarily protect against aspiration, but it does have a suction port alongside of the airway port, so that way you can theoretically provide some suction through it. Very nice device. A lot of places are using it. Unfortunately, I don't have a slide of the AirQ3, which is an even newer device. that has come on the market and is essentially, again, like one of these laryngeal mask airways, like the iGel, except instead of it having gel, it goes back to having air. But this time, the balloon actually inflates further when you bag the person. Um, the problems that you're going to have with any of these airways is making sure that you've got a good seal, okay, and that you're not getting leakage kind of around the edges of the device. The manufacturer says that because their balloon inflates, even more during the high pressure part of ventilation, that it should create a better seal. Whether that's true or not, I don't know. There's not a ton of data on it, just like there isn't a ton of data on the iGels. Um, so as a result, I'm fine with the use of the AirQ3, but by no means is it superior at this point to anything else. The AirQ3 also has a vomit port, a suction port that you can put down through it, which is nice compared to the King Airway. Video laryngoscopy is another thing that has become more widely adopted. Initially, these devices were incredibly expensive. So this um, Ranger device here that you see originally was around $20,000, okay? And it was designed for field use. Having seen these in real life, I guarantee you they are not firefighter proof. Um, they get dropped and they break. And that is a very expensive piece of machinery to break and have to write a Dear Chief letter about. Great device, but not really ready for prime time. And so they've made multiple adjustments to the various video laryngoscopes over the years. And because the devices have become more widespread, they're now significantly cheaper. You can get devices as little as $1,000. There may even be some that are less than that. But most of them tend to be in that $3,000 to $5,000 range. So still a chunk of change, but it's not 20 grand chunk of change. All of these still use an endotracheal tube. Some of them have a little passageway kind of along the edge of the handle itself so that you can pass an endotracheal tube down that kind of passageway. Not all of them have that. I personally prefer not to have that passageway there. I think it just gets in the way. Again, if you're looking at getting one of these, I would highly recommend that you get a bunch of them to play with. So talk to the equipment representatives and play with some and get a feel for it. More and more emergency room physicians are now using this really as honestly their first shot. This is what they're grabbing to do the airways. I was one of the few people that still continued to use the regular laryngoscope. And the reason for that is because I'm still out in the field with you guys. I may have to intubate in the middle of a cornfield at noon in August. Okay. Guess what? A screen, no matter how good it is probably going to have some degree of washout. And some of that washout can be really profound. So if you're not good at doing regular laryngoscopy, you're hosed. My experience has been that it is very hard once you start relying entirely upon the video laryngoscope. It is very hard to go back to using a regular laryngoscope because you don't have to work as hard. It's not as hard to get a good view because you're looking at a camera that's now deep within that person's mouth. So I would use this as my second shot, or if I predicted that this airway was going to be, difficult, okay, maybe I am going to use it as my first shot. But I personally highly recommend continuing to use the regular laryngoscope, and then relying on this as kind of a backup to your regular laryngoscope. Interestingly, there was a study done. There's actually been a couple of follow-up studies done where video laryngoscopy actually doesn't really help us. It doesn't improve our success rate. So essentially what it's doing is it's giving us a better view of something that we still cannot intubate. Okay. So it doesn't improve our ability to suddenly secure that airway. It does, and at least one of these studies showed that for these predicted difficult airways, it may decrease the time required for intubation. And whether that's because you have a better view and so you now know, kind of what you're dealing with and how to overcome it. But overall, again, it does not increase your success rate. These still have a high failure rate, just like regular endotracheal intubation in these difficult airways. All right, so let's talk quickly about failed airways. Cricothyrotomy is, kind of the last resort. This person is going to die if I don't get control over this person's airway now. Okay. So this really needs to be used in situations where regular intubation or supraglottic airways are not going to work because of, trauma or, something along those lines. Um, or we're in one of those scenarios where we cannot oxygenate and we cannot ventilate. And so this person's going to be dead within a couple of minutes if we don't get, some sort of an airway established. This can be performed open or through kind of a modified Seldinger technique. That means that there is a kit that's on the market where you use a needle to puncture that cricothyroid membrane. You then pass a wire down that needle, remove the needle, and now you've got essentially this wire that's leading into that person's trachea. You then take a dilator that's got a tracheostomy tube attached to it, and you pass that down. And instead of it cutting the tissue, it spreads the tissue apart. Okay, so you're not nearly, hopefully, as bloody. And then once you've got that tracheostomy tube all the way in and hubbed, you then remove the wire and that dilator, and now you've got your airway established. Most of the time in the field, we're using either one of the quick trach type devices or we're using an open technique, simply because those Seldinger techniques are technically a little bit more difficult and take longer to do, especially if you're not used to working with one of those wires. Those wires can be a little wonky. It's a paramedic only skill. It needs to be practiced regularly. And there's lots of data that shows that it's very effective, but most of those were done in military settings. And in the military, they rely on these much more aggressively because it's hard to get somebody intubated when you're actively being shot at. If you open up a laryngoscope, guess what? That light just gave away your position potentially. And so you've now put your whole crew in danger. So they will train prior to deployment on how to do these in minimal light to no light scenarios. Once you basically make that cut, at that point, it becomes a field because there's now going to be blood in that field. And so you're going to do the rest of this with your fingers. You're going to not need to rely on your eyes to do the rest of it. There is limited data in the pre-hospital setting. Anybody that's had to do this will say that it's a very difficult decision to make, that it can be bloody. But again, the alternative is this person's potentially dead. And so we need to make sure that when we're charting something like this, that we're really calling out, this is why I had to resort to this, and spell it out. You need to paint a picture because these are pretty significant things and they're going to get reviewed, and they may even trigger lawsuits, et cetera. And so being able to document at the time what your logic was in needing to go to one of these is extremely important. Just make sure that you're spelling out your logic really well in that narrative because that's what's going to potentially save you. All right, so some of you guys have seen this before, the real deal cricothyrotomy. Give me a second to share the computer sound. All right, so we're going to see an actual cricothyrotomy being done. there is going to be blood. It is somewhat graphic, etc., but I think is well worth it. So here we go. So pretty intense. This is still one of the best videos that I have been able to find of an actual crike being performed on a live patient. And if you think about it, these are generally emergent things. It's, I need to do this right now. And so nobody thinks of, hey, somebody should record this. Um, and so as a result, we don't have very many videos that are like this. And I think it was because they were, somewhat stable and yet still needed to have this done. And that I think there were multiple attending physicians in that room. So it meant that somebody had the, knowledge to say, hey, this is really educational. We should probably try and capture this because we have, all the hands that we need. But this goes to show you that, this is something that we could encounter very easily in the field. Thank goodness this guy was able to be bagged successfully because otherwise, this would have been done out in the field. A couple of things that I want to highlight are, again, it's really important when you're doing this that that cut through the skin is vertical, okay? If you make the first cut horizontal, you run a real risk of hitting one of the thyroid arteries or the jugulars. So it's very easy to turn this from something that is a little bit bloody to something that is incredibly bloody and potentially life-threatening, more so than the airway stuff even. So very easy to forget about that. So first cut is always vertical. It's only when you get down to the membrane that you go horizontal, okay? So where do we carry this stuff? Well, unfortunately, we don't have like, crike kits in a lot of places. Luckily here at Sharonville, we do. We carry an all-in-one crike kit. More and more places are getting to one of these kind of EMS designed crike kits. If you don't have one though, it really only requires a couple pieces of equipment. You need a scalpel, which you can get out of the OB kit. You need a bougie, which obviously is with the airway stuff. You need an endotracheal tube to actually pass down into the airway, and then a 10 cc syringe, to inflate the cuff. Because we're going to probably be using an endotracheal tube if we're doing these emergently, the commercial securing devices work just fine for this. Obviously, you can't make it too tight because then you're pushing on the carotids, which is not good. But you can use those commercial securing devices to do it. The all-in-one kits, like some of us carry, already have the appropriate securing equipment within the kit itself. So easy to find. Again, highly encourage you, pull out your department's cricothyrotomy trainer, do it a couple of times, refamiliarize yourself with it, because when you need it, you need it. All right, so we've got our tube in. Now what? Well, we've got to make sure that we confirm placement. And so we want to do this by, auscultating and a clinical exam. The chest is rising equally. We see fogging in the tube, et cetera. But we've also got to use end-tidal CO2, okay? Not only is it the right thing to do, it's also in the state of Ohio, the law. This is so important that they actually passed a law a few years ago saying that end-tidal capnography has to be on EMS patients that have advanced airways until care is transitioned to the hospital. So this is not something that you can disconnect from the monitor and take them in, off monitor. It's got to be on the whole time. It's also really, really important that you leave them on this when you're moving them over onto the hospital bed. Because the last thing any of us want is for one of you to be accused of, oh, it's in the wrong spot. You never actually were in the right spot. It's easy for them to say that if we don't have capnography readings the entire time. So leave them hooked up until they're over on the hospital bed, and then respiratory can do whatever they want with it. But the last movement has occurred. It's now their patient. If it gets dislodged after that point, it's not on us. So, because I've run into that previously. So waveform capnography is what most of us use. It's built into most monitors these days. You can get, tube-based ones like we talked about last month, et cetera, but highly recommend that if you're speccing out a new monitor that you get it with end-tidal capnography. Couple things to remember though is if you're in a low perfusion state, that means that your body is not getting enough nutrients, et cetera, to metabolize. And so if you're not metabolizing, that means you're not producing carbon dioxide, which means then your end tidal is going to be low. And so there can be confusion over tube placement. So this would be your sepsis patient, your cardiac arrest patient. Really important to look at the waveform, okay? If the waveform still is showing normal waves, even if the number is low, you're probably in the right spot. It's just a low production of end tidal of CO2. Whereas, last month we kind of went over what a dislodged tube looks like, and it's very erratic. There is no real identifiable waveform. And so that's an indication that you're in the wrong spot. All right. So to wrap things up, intubation in the field is risky, but we've sometimes got to do it. It's important that we have a bunch of tools in the toolbox, so that way you can approach things differently, but it's important that you know which tool to pull out for what patient. Always think 3 steps ahead. You want to make sure that your plan A isn't your only plan. You need to have a plan B, a plan C, potentially even a plan D. So that way, when you get to the point where plan A has failed, you're not scrambling trying to come up with what am I going to do next? You know that I'm going to go to, this thing versus that thing. And don't forget about your surgical airways. It's not something that you should do, very often, if at all. But it's important that you know how to do it for that once or twice in a career thing where you really do need to do it. All right. Any questions? Otherwise, I'm going to share a different thing. Give me just a second. All right. So this is kind of Tom's airway protocol. This is how I would approach most airways. All right. So we recognize the fact that we need airway control. So we predict our airway using that 3-3-2 rule and the Mallampati. If we predict that it's going to be difficult, we should attempt an I-gel first. Okay. And if that's successful, great. We've got an airway. All right. But if that fails, if they're easy to bag with nasopharyngeal and oropharyngeal airways in place, we just continue to bag them. That's good enough. All right. But if they're difficult to bag despite that stuff, then we're stuck. We've got to attempt intubation, and then a second paramedic maybe needs to attempt intubation. And only then do we get to the point where, okay, we've now exhausted everything. We now have a surgical airway. If we predict that it's going to be straightforward, we attempt intubation. If we're successful, great, secure the airway. But if not, second paramedic can attempt, okay? Again, if they're successful, we just secure the airway. But if they fail, again, if they're easy to bag, we just keep bagging them, okay? It's good enough. If they're difficult to bag, again, despite that OPA, NPA, we do an I-gel. And if that fails, we then go to a surgical airway. But that's the way I typically would approach these, because again, if they're easy to bag and that is adequate, it's better to potentially transport with that in place, and let the hospital in a more controlled environment with more equipment, potentially do the airway. But it's important that you kind of know how you're going to play things out in your mind. So that's why I came up with this, and I'm happy to email it to whoever wants it. So.
Can you email that to me? It's Wendy.
Yeah.
Thanks.
Yeah, absolutely. And somewhere I still have the Visio file that I used to create it, so we can swap out that iGel for the AirQ3. But you get the concept.
Great. Thank you.